Welcome everyone to the West Australian Primary Health Alliance COVID-19 Immunisation Update. Tonight we have colleagues from Primary Care, WAPHA and the State Health Department to walk us through the changes in recommendations for the COVID immunisation. Before we begin our discussion, let us pause and acknowledge the traditional custodians of the lands on which we meet and pay our respects to their elders, past, present, and emerging. There are almost 500 practices across WA that are participating in the Phase 1B COVID-19 vaccine rollout. We're very grateful to you for your willingness to be involved in this enormous response to the COVID-19 rollout to ensure the health and safety of our communities. Not all of the 500 practices are online tonight, but we do have people ranging from Esperance in the far south to Warrakamia up in South Headland. And our thoughts go out to our colleagues in the Midwest who aren't able to join us tonight. I'm not sure that they've got their electricity back. So we've gathered questions from those who have registered, from all of the participants that have registered, and we will endeavour to answer some of these in our discussions. The questions posted during the webinar will be collected and we will respond to those and provide those answers early next week. We will also record this presentation and we will provide all of the resources that are mentioned by our speakers tonight. So tonight we intend to provide information for you to understand that the COVID rollout is an evolving process. It is dynamic. We all know that there have been rapid changes from the Commonwealth recommendations regarding safety and storage of vaccines. We're going to focus our information and advice tonight on that is being provided by the Commonwealth Government, so not our personal opinions. We will also advise when something is unknown because of the rapidly changing or the fact that the advice hasn't been provided as yet. We all know with continuous improvements, as we've seen in the last week, if new information emerges, we will advise and change the changes rapidly. So let me introduce our panel. We have Dr. Richard Choong, who is the chair of the WA Primary Health Alliance, a GP and principal practice owner in an outer metropolitan general practice in Perth. Richard is going to ask some probing questions as we go through, but he's also going to sit back so that he can summarise the proceedings this evening. Thanks, Richard. We have Professor Paul Effler. He holds many positions, but he is with us tonight as the public health physician and the senior medical advisor within the Communicable Disease Control Directorate at the WA Department of Health. Welcome. Dr. Shaun Stevens is the chair of the Royal College of General Practices. He is a GP and the owner of a metropolitan general practice and one of WA's GP-led respiratory clinics. Welcome, Shaun. And Lucy Patel is acting general manager of WAPHA's Primary Care Innovation and Development Portfolio and is leading WAPHA's COVID-19 vaccination program across general practice, residential aged care and residential disability services. And she has an army of people assisting her. I'm Dianne Bianchini, also from WAPHA, and it's my privilege to be chairing tonight's proceedings. So Paul, I'm going to ask you the first question, and I will then invite others in the panel to make some comment. Last week, the Commonwealth Government took advice from the Australian Technical Advisory Group on Immunisation, we'll call it a TAGI from now on the risk of blood clotting side effects of AstraZeneca for under 50-year-olds. Based on that advice, the Commonwealth recommended the Pfizer vaccine be provided to adults under the age of 50. Can you please explain to us their reasoning for the age cutoff?
Sure. So that reflects calculation of the risk and benefits by age group. And essentially, in the math was a consideration that people 50 and over have a much greater risk of being hospitalized or becoming seriously ill from COVID. And there would appear to be some preliminary data to suggest that people older than 50 are less likely to end up with the blood clots that had been reported from the UK and Europe and now the United States and Australia. Although that information is less robust. And if you read the Atagi statement, I think it reflects that. It says that it may be decreased in younger people, in older people as far as the risk, but it doesn't make a firm statement to that effect.
Okay. So before we commenced our discussion tonight, you showed us an infographic that you have been using, and I know Choong has been using with his patients. I wonder, Choong, whether or not you can talk us through how your patients have found that information and responded to it.
Look, I think Diet's been really valuable. It's hard. You start talking numbers, and if you actually do studies on it, patients tune out, and that they just, their eyes glaze over, and the information's lost. To have a graph and to demonstrate and say, look, you're this age, your risk from vaccination is 1 in 300,000 or whatever it is. Your risk if you get COVID is whatever, and you can point to that. Then I think that that information that individualizes it is a lot more powerful, and it also simplifies it, because these can be really long conversations. If you get right down into the weeds, it can go for a long time.
And I'm going to come back to you, Choong, later on in terms of the time it takes to have that conversation. But Paul, coming back to you, we've had quite a few questions from the audience in terms of the Pfizer vaccine. So if I can just ask you a couple, and if you could respond to them. So question 1 was, can the Pfizer vaccine be provided to health workers under the age of 50 now? And question 2, when will patients under the age of 50 years old be able to register for the Pfizer vaccine? And where do we refer them?
Okay, those are great questions. They essentially have the same answer. Our issue, both those groups would be eligible to get Pfizer vaccine. If you're under 50 and a healthcare worker or other individuals, we want to be able to give you Pfizer. Our issue now is we don't have supply. We don't have supply in Australia and in Western Australia as a consequence to be able to meet the demands for those legitimate requests that we're trying to fulfill. So I can't give you an answer now. We don't have a waiting list established going into the future. What I can say is the Commonwealth earlier in the year had said they had contracted for 20 million doses of Pfizer by the end of this year. And in response to the developments with the AstraZeneca vaccine, have gone and procured another 20 million doses. So that would say to me, if we're getting 40 million doses and it's 2 doses apiece, that's 20 million people that will ultimately be able to get Pfizer vaccine, which is probably the entire adult population over 16 years of age in Australia. So I guess it's an issue of the timing of the vaccine. It should not be an issue of eventual supply.
Excellent. It's a great example of, we know some facts in terms of the amount of the vaccine, but we don't know when it's going to be available. Lucy,
I hope it's just not a Christmas present, all in one lump sum.
Indeed. Lucy, I wonder whether or not there's information within WAPHA on our website, etc., that we can refer our participants to on that issue regarding Pfizer.
Yeah, thanks, Dianne. So we're trying to keep the information housed on our Practice Assist website. So as it comes to us from the different sources, be the Commonwealth or the WA Department of Health, we're housing that on Practice Assist and trying to structure it into some frequently asked questions so you can find the information easily. And where we can, we're linking back to the source of that information so that if it does change, you're always being linked back to the most up-to-date resources. And we do have links to both the Commonwealth, COVID-19 pages and the WA Department of Health pages as well.
Great, thanks, Lucy. And again, we will be sending out any information that our panelists talk about tonight, all the information Lucy's just talked about, and the infographic that was spoken about before. We'll be sending that out to all the participants early next week with the answers to the questions that we don't get to. But Choong, I'm going to come to you. There were a couple of other follow-up questions regarding Pfizer or the Pfizer vaccine. And this question is coming to you because you have a GP-led respiratory clinic. The question is, do you think the Pfizer vaccines will be made available to GP respiratory clinics now that they've been found to maintain stability when stored at -20 degrees?
Yeah, very good question, Diane. Look, I would hope so, but this, things are in such a state of flux at the moment. It really does depend. Freezers, vaccine freezers, other than the standard vaccine, 2 to 8 degrees, are in very short supply. So, certainly the -70s, I think, the government's even had difficulty getting a hold of. Whether we can get a fridge or freezer that is suitable to store for 14 days at -20, that really is going to be the key. And I think, if I was a betting person, I would say if that issue can be solved, then I would think that the government would be doing that. But that's, I have to put a caveat there. That's my personal opinion. That's not formal policy.
Okay. Thanks, Choong. And Paul, I can see your fingers coming up, but I was going to ask you a question anyway. So you go first and then I'll ask my follow-up question.
Sure. I would say that, I think I've been advising government, and I think we need to plan for large amounts of Pfizer to make it through the system ultimately. And I think in this time where we don't have supply, we should still be marking out in careful detail how we're going to get Pfizer out across the state. And whether that includes defrosting, thawing it out and sending it to GPs and they have a 5-day window to use it, or whether it means we identify what kind of freezers that can work in GP practices and how we're going to get it to remote areas of our state to serve remote communities. I think that's the planning we need to do now in this while we're waiting for it to arrive, so that when it comes, and I'd actually even test it, right? I'd actually send product out with temperature monitors on it and just run it to ground to make sure we're ready to go when the vaccine drops. Because if 40 million doses are coming by the end of the year, we don't want to have it backed up in -70 freezers and not getting into people's arms.
And Diane, sorry, if I can just expand on that, I could not agree more. I mean, Paul and I have had meetings regarding this, and that is just pure common sense. The trouble is, common sense is not all that common. So Paul's a lone voice sometimes. So no, well said, Paul.
All right, and we clearly have seen examples of that in other countries. Richard, were you wanting to make a comment there?
Yeah, I just want to quiz Paul and Choong about what's just been said. So we've got 40 million doses of COVID. We've got a large percentage of the population that are very vaccine cautious now because of recent media. There's going to be questions coming up to every GP that shouldn't I just wait for Pfizer to be available? So inadvertently, we end up slowing up the AstraZeneca rollout, because patients are willing to wait, and they do the risk analysis themselves and they think, well, Australia's a pretty safe place. No one's coming in. There's not a lot of cases around. Isn't it better for me to wait? I'd just like to know how you'd answer that question.
So Choong, you put your hand up first. So we'll come to you first and get your response. And I'm sure Paul's got a response. And then I've got some other questions regarding the Pfizer vaccine. Choong.
Yeah, look, Richard, good question. And if I can just give you some stats in the last 2 days from our respiratory clinic, we get 800 doses of AstraZeneca. If you took us back 1 week, we were booked out about 3 weeks ahead, doing 150 to 200 patients on a full day. We had 300 people booked today, if you look a couple of days ago. all bar 30 had cancelled. You know, it was tumbleweeds, and that is the experience of most other GP-led respiratory clinics. Now, I think you're right. A lot of that is being driven by the media. Part of it, I think, is also being driven by now the health department having mass vaccination clinics, although they tell me, and Paul can probably speak to this more than me, that a lot of their clinics are empty as well. Yeah, it's a big issue.
Yeah, so I could comment on that. I understand that for a lot of our sites, you know, people are voting with their feet and not showing up to their appointments and canceling. There are some exceptions, however. We see there seems to be, you know, that cohort of older folks over 70, strong confidence in vaccine science because they've lived through polio and other situations before. And we are finding that they are actually going out and telling friends and other groups that they are part of to come in and get vaccinated. And so we've started to allow some walk-in vaccinations at some of our clinics. So I do think there is a group out there that, you know, want the vaccine. They're fine with the risk of AstraZeneca as it's been presented. And we probably need to take care of that community first up, the low-hanging fruit, if I could say it that way, of people that want to be vaccinated to get them in. But then to respond to the question, I think even ATAGI has recognized this issue is going to come up in their statement, because I'll read. It says, ATAGI supports the Australian government's ongoing efforts to procure more and bring forward the delivery of alternate COVID-19 vaccines to replace the use of AstraZeneca in people that couldn't get it. So I think there's recognition at the highest level that people are potentially going to wait, and that we need to try and bring forward those Pfizer doses so that we can get Australia protected in a timely way.
Thank you for that. Thanks for the question, Richard. Before we leave the Pfizer vaccine discussion, Paul, I want to come to you and ask you if you can explain and provide confidence over the change of temperature that vaccine is being held at. If you can comment on that.
Sure.
So that
I mean, that's been studied, been shown to be effective, so I don't think it's super complicated. The Moderna vaccine, which we're not using, is also made the same exact way, an mRNA vaccine in a lipid nano layer, and that one has always been able to be kept at higher temperatures. So I think it's what they had was they started with the conservative, which is -70, and now they've tested it in warmer and warmer temperatures, and they're finding out that that's okay. And that's a great advance for helping us get Pfizer out to more locations. And as you commented, there are countries in the world that are doing this, even with the American poor public health infrastructure. You know, they're doing 4 million vaccinations a day and up to probably 80 million doses of Pfizer and 70 million doses of Moderna. They're only one example. The UK's done it as well, and Israel's done it. So we should be going to those places, I think, and looking at how they've been able to do that. And if they haven't, and if they've been able to get it out into primary care, what's the successes in that, and what are the risks to mitigate against?
Excellent. Look, thanks, Paul, for that. Choong, I'm going to come to you now because as we talked about, you know, the media has got lots of messages happening, and the media and the Commonwealth Government have commented on the medico-legal issues for GPs, particularly now that greater risk is apparent for under 50-year-olds in relation to the AstraZeneca vaccine. What issues are being raised by your members in the RACGP, and is there any reassurance that you can provide from the Commonwealth or messages that you want to provide tonight?
Well, what I would say, so there's a lot going on behind the scenes on this, because it's a very live issue. You know, there's been assurances from the Prime Minister that any vaccinator who has an adverse event and runs into medico-legal trouble, that they will be covered. I mean, personally, that's, you know, from the college perspective, I don't think just a letter saying that is enough. The negotiations behind the scene are looking at a couple of options. So one is 100% coverage for the MDOs for any large claims. So you need to understand, I mean, I don't understand it fully myself, but basically if there's a very large claim, there's the government will step in and cover 50%, and particularly if it's a class type thing. What the government's looking at doing is coming in and covering 100% of any large class type issues that pertain to COVID vaccination. So that's one option. Another option, which I think in my mind is probably preferable, is the option that's available in New Zealand, America, Quebec, a number of Western countries, where you have a no-fault injury compensation scheme for people who are who suffer an adverse outcome as a result of any vaccination. In our case, we might start with just COVID. And, you know, from an ethical point of view, people are taking a personal risk, yes, to help protect themselves, but also to help protect society. And as a society, I think we owe a duty of care to people who are taking that risk and protecting the unvaccinated. So it's a big issue, but yes, and the college is working very hard behind the scenes on this issue.
Thank you for that, Sean. Paul?
And I'm super happy to hear that. And Sean and I have talked about no-fault vaccine injury compensation before. Just for some background, it's been something that's been proposed in Australia for decades. It has strong support of the Public Health Association of Australia, with multiple resolutions, conference resolutions saying we need to work for this, because it's good for the vaccination programs because it instills confidence. And at the same time, it's social justice for individuals that step up and might have a super rare event happen, but it happens to them. So as Sean said, there's 25 countries around the world have these. Every country with an advanced economy has this really, but Australia. And I think these events that we've heard about over the last week really illustrate why this is important. And it doesn't necessarily cost a lot of money. In the US, they charge the manufacturers a small surcharge for each vaccine they sell. And last time I checked was a few years ago, but there's $3 billion in that account, because the pay in is so much greater than the payout. So it won't necessarily hike all our taxes tremendously. Over.
Thank you for that, Paul. I'm just going to ask Lucy and bring her into this, because I think our health pathways are pretty clear in terms of the consent issues that need to be gone into. Can you speak to that, Lucy?
Yeah, thanks, Dianne. So we've got a clinical editor, GP clinical editor at the moment, dedicated to just keeping the suite of health pathways up to date. So she does an awful lot of work every day, reading all of the changes that are coming through and making sure they're reflected in the suite of pathways. So as the Commonwealth updated their consent form, that information was included in the pathway, so that for you as GPs, you can only remember one place to go to find that information, because I know it's coming at you from lots of places.
Okay.
But
excellent, thanks, Lucy. As you can imagine, it takes a lot of people to put on a panel discussion and a webinar like this. And I'm getting some texts from our helpers who are outside, and they're saying that there's a lot of interest in terms of talking more about the cancellation of appointments for vaccines. And I'm going to come to that later on in the panel discussion. So hold tight, we'll get to that. There's also been some questions coming in tonight about MBS items and the financial issues for GPs being part of this rollout. So Sean, there have been many reports, and the questions that I've said that have come through tonight, re MBS items not being or being inadequate for the cost of the now extensive conversations that you need to have with someone around the COVID vaccine. Can you talk to us about whether or not those concerns are evident in WA, and is there anything that the RACGP is doing in that space?
Look, absolutely. This is a red hot issue nationally. and the college is in daily meetings with the health department about this. You know, the media around GPs actually saying, you know what, this is too hard. I'm stopping until there's a bit of clarity, has really caused a lot of political traction. And you know, the government doesn't want to see the rollout slow down any more than it needs to. The payment for it, you know, there was hard negotiations behind the scene for the college and the AMA with the government. You know, I thought even back then that the rebate was inadequate. It was done on the understanding that it was a mass vaccination program, so that it would, you know, everyone would be lining up for it, and then it would be very efficient. And you know, a level A consult with the bulk bill and the practice incentive and blah 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 would be enough to cover it. That's clearly not the case now, and I think, you know, the feedback I've got, I contacted our person in Canberra who's negotiating with this. He said that, you know, the government realises that the game has changed. The things we're looking at the moment is to have increased payment to reflect the time that it's taking. The two things, a number of options are on the table. The two that we're sort of looking at the moment are either a vaccine counselling item number, which is, you know, much bigger than just a level A, or the co-claiming of the current item number for COVID vaccination counselling, plus a longer consultation if it goes beyond a certain time frame. And there's a couple of other little nuances, and there's always bits and pieces around it, you know, horse trading. But that seems to be where the negotiations are up to at the moment. And the college will keep people informed as things developed. If I could just hark back briefly to previous discussions about information and getting timely information out, just put in a small plug for the college. RSCGP WA faculty has established a WA specific COVID immunisation WhatsApp group. So most people will be familiar with WhatsApp, but it allows us to get this sort of information out really quick. And it's been a great mechanism for rapidly breaking news. So if people want to join that, we'll have some information in the stuff coming out after the webinar.
Thanks again, Choong, for that. I'm just going to ask you, I've got some hands. I've got Lucy with her hand up, so I'll go to her. I might come back to you, Choong, on that.
I was just going to mention that the Commonwealth are actively asking the PHNs to ring practices who are reducing their orders to find out why, so they can understand what the issues are for the practices that's driving them to reduce their vaccine orders. And I know that they're really keen to gather all of that information, because that will really inform the next stage of planning that they're looking to do.
Thanks for that, Lucy. It's a really important role that the PHNs provide across the country, feeding back information to the Commonwealth. Paul.
Yeah, I just want to pick up on Sean's comments. I think that WhatsApp group is good because we may need to disseminate information really quickly, and a WhatsApp is a very efficient way to do that, or a timely way to do it. But also to say that I can understand the issues about how long it is taking to get informed consent potentially. I still see patients one session a week, and I'm pretty familiar what it requires to give informed consent before vaccination or injection of antibiotics. And I think it's a challenge, because and it's recognized by ATAGI, if you go to their guidance, it actually says, their most recent guidance, ATAGI recognized it is difficult for people to assess their personal risk where there's uncertainty about the short and long-term risk of severe COVID in different age groups, and the evidence around benefit and risk of the AstraZeneca vaccine is changing quickly. And that's, I think, a real issue for getting informed consent, is the rapidity with which things can change, and how does a patient and their provider really frame up that risk in this environment of uncertainty.
Paul, that's a great point, and it leads straight back to the question that I was going to ask Choong. And Choong, I'm going to ask you in terms of you talking about your practice wisdom. How is it that you're going about talking with your patients, gaining consent, while you're doing the, the policy work at the Commonwealth level. But I wonder whether you can share some of the things that you've found to be helpful at a practice level for our audience.
Sure. So it's a little different. We're not vaccinating from our regular general practice side of the business. We're only vaccinating from our GP-led respiratory clinic side. Was able, because we're getting 800 doses a week, we were able to streamline things. So we really try to automate things as much as possible. If people haven't yet opened up their vaccine line, I think even now you would find that, don't give your main clinic phone number as the line to call to book vaccinations. I've got colleagues who did that and it caused chaos. We had a dedicated phone line for the respiratory clinic, which we use for the vaccine bookings. However, we also still try to divert people away from booking via phone. A couple of reasons. A, it doesn't tie up the phone. B, you're not having to pay a staff member to deal with what is a fairly mundane task. And C, it allows you to automate the process so the patient goes through and has to give consent, and it outlines things in advance of presenting. So that way the people who are rolling up have already really given consent. Now you still have to obtain and document verbal consent. You don't have to get a signed consent form done. That's not a requirement. But if they've gone through, they've ticked the box, you've got proof online that they've consented to it. You then, when they come in, you say, look, and then there's the questions when they sit down around the CVST and the, the heparin-induced thrombocytopenia and other issues. And then they have a read of that while everything's getting set up. We do it in modules of 5 people per room. They don't all have to know each other. So it's, again, it's a mass vaccination type setting. And we say, look, has everyone done the online consent? Do you have any questions? Have you read the sheet that's in front of you? Is everyone happy to proceed? And then you go around and you do it, and then you've got to make sure that you then enter it correctly. And the key thing is uploading it to AIR, the Australian Immunisation Registry, because that then signals the recall. It then allows them to provide proof to their employer, etc., that they've been vaccinated, and then they wait their 15 minutes or 30 if they've got a history of anaphylaxis, and next 5.
Choong, thank you for going into that level of detail. I know there are participants in our audience who have those processes and have other processes as well working really well. But for many of the participants, the questions they were asking for some very practical detail. So you've provided that. But I'm also going to come to Lucy, because I'm assuming the Commonwealth is putting out information for consumers.
Yeah, the Commonwealth did prioritise updating their suite of consumer information as soon as the changes to the AstraZeneca were announced. And they provide us with that information, so they're emailing it directly out if they have a general practice contact information, and we're also sending out that information in our special bulletins over the weekend when it was coming to us, and then regularly linking back to those patient information leaflets as well in our twice weekly immunisation bulletin. We've also got it links to them from our Practice Assist website, so we're trying to put links in as many places as possible based on your preference of whether you want to get the information yourself from the website or whether you'd prefer to get a bulletin with all of the links summarised in.
Thanks, Lucy. Hopefully we'll have time at the end. We've got a lovely comment from someone in the audience about too many emails, where do we go for it? So we'll cover that off later on. I'm just going to remind people to keep posting your questions. They're really important. If we can't answer them as we're going through, we will respond to them and send out, really thought through responses early next week. Again, with all of the links to the resources that we're discussing. Now, Lucy, I'm going to come to you because we've touched on the role of WAPHA. So WAPHA has a range of roles with respect to COVID-19 response, and you've been at the forefront of these from the early days when everyone was talking about PPE distribution and the role, and now you're involved with the rollout of the vaccines. So what is WAPHA currently being asked to do by the Commonwealth?
Great question, thanks, Diane. So we do have a few roles that the Commonwealth have asked us to assist with. I'll start with probably the least interesting ones first and come to the ones that are going to interest you the most. So with the rollout with disability residential facilities, the Commonwealth have flagged that there will be a role for PHNs, but we haven't had any clarity at this point what that role will be. It's likely to be a communication role in amplifying any messages that are going out to the sector and making sure that GPs who visit in those facilities are aware of what that rollout plan is. The rollout plan is in the mix for what the new plan is going to be. So we don't really, not too sure what that plan is at the moment, but we will keep you updated on that as we get more information. We're also involved in the residential aged care rollout programme, and we're really taking on the role of liaising between the residential aged care facilities and the vaccine provider that the Commonwealth has contracted, just to make sure that they're communicating well and that the residential aged care facilities are supported in communicating with the GPs who are looking after the patients in their facilities. And with our role for general practice is to make sure that you're getting the messages and the updates as they're coming through from the Commonwealth. We're also listening to the feedback that you're providing to us and escalating that back to the Commonwealth so they can consider that and can continue to make improvements to the programme. We do know that there are some issues with some clinics appearing on the clinic finder, so we are advocating really hard on behalf of those practices for those issues to be resolved quickly. And they've also asked us now to take on that role of calling practices who are reducing their vaccine orders just to try and understand why that is. So a few different roles. In the Aboriginal health space, we've been asked just to form some stakeholder groups and make sure that they're included in any plans. And Chris Kane, who's our General Manager for Strategy and Policy, is leading that piece of work.
Okay, it's busy. You know, as an employee of WAPHA, I'm immensely proud of what our colleagues are undertaking in this quite pressured environment. And similarly, it's pressured in general practice. We have no doubt in terms of that. I'm going to come back to Choong in terms of the media really promoting the issue in terms of vaccine hesitancy. And we have seen from the questions that we got when people registered for this webinar and some of the questions coming through as we've been talking, that that's a real issue. So I'm wondering whether or not you can speak to how your practice is dealing with that. You talked earlier about the cancellations. Do you have a response for that?
Well, that's one of the issues, is if people are booking online, then they're usually cancelling online. So we're not getting a great read of how and why and what and you know, but it's not really the place to do any counselling over the phone either. I think, you know, there's two levels to your question there, if I'm understanding the question correctly, Diane. There's what do we do at the sort of level of liaising and dealing with the media, and then there's the level of what do we do at the practice level and at the individual level of doctors, GPs, dealing with their patients. So perhaps if I take the practice level first, sorry, the higher level first. Look, I actually think despite the way media is reporting these events, they are generally very pro-vaccination, mainstream media I'm talking about here. In my discussions with them offline, they're actually, you know, around, oh, well, this is very rare, and, you know, and I don't need to explain that to them. They're aware of that and they're trying to emphasize that. The trouble is the story of a clot and somebody, lying in hospital in Darwin is almost irresistible to a journalist, and it does have a lot of public interest. And I don't think we should try and hide that either. These things happen. We've got to be honest. They are the longer form of journalism is willing to talk about these issues and deal with them. And I think we've just got to get the message out that way. I think we could, however, from our government, get clearer messaging around this and deal with the, and try and get their message clear so then the media can report more clearly. Sorry,
Yeah, thanks, Sean. No, I think that's a great response. And Paul, I'm wondering whether or not you can comment, but also speak from the broader public health strategy messages, because if people lose faith in our immunisation campaign, that will have a lot of repercussions across the board. Paul?
Well, I think you have two things here, and the first comment I was gonna make is the issues around public confidence, where they're always from the start with vaccines that are new and they rolled out relatively quickly. But AstraZeneca had a special issue because of its effectiveness dialogue, right? There was a lot of discussion here in Australia amongst professionals and worldwide. It's not as effective as Pfizer. And that was already coming through to us with trying to book our clinics and people wanting to make sure they ended up with Pfizer. The safety issue that's been emerging in the UK and Europe has just compounded this issue for some people, right? There are, as I mentioned, there are the folks that are strongly pro-vaccination and trust in it and will carry forward. But I think we need to be careful here. This is a adenovirus vector vaccine issue, as far as we know, and that Atagi is pretty clear that this is not related for Pfizer. And if we're careless, we might actually reduce confidence in all vaccines when people are they're voting with their feet, as I said, and not showing up to our AstraZeneca clinics. They're coming to our Pfizer clinics and they're trying to get into our Pfizer clinics. So they are distinct issues, I believe, and probably for to be honest, we need to be upfront about that, but also ultimately for the good of the program, I think we need to be frank.
Thanks, Paul, for that. Richard?
Just want to clarify, it's along the lines of a question I asked previously. So we have a vaccine, Pfizer, which appears to be more effective and in some degree safer, but it has technical issues about storage and delivery, versus one that we're trying to roll out, which is plagued by issues of effectiveness and now safety. So it's further putting us into an awkward situation as GPs trying to promote this vaccine. And Sean's touched on it before about consent and having appropriate time to actually counsel the patient. But why would we not just wait? This is what I want to try and clarify. So for everyone listening, is that the question is obvious. Why wouldn't I just wait to vaccinate my patients with Pfizer?
Can I run through two scenarios that might illustrate it? And before I do that, I do want to say that the emerging real world data on the effectiveness of AstraZeneca it matches Pfizer, right? And it's data coming out of Scotland. So I think the effectiveness issue in my mind is pretty much been put to rest by the real world experience, especially against serious illness. Having said that, this issue of why not wait, I guess you frame it up in, at least for myself, I frame it up in two scenarios. If we were getting, starting next week, 1 million doses of Pfizer coming into the country every week, I would think, yeah, why don't we just give people the Pfizer they seem to want and just let it take over the program? But if you told me we're going to have to wait to December to get this load, then you're doing math of what's the probability we can keep COVID at bay in Australia, and what's the cost of that? I mean, I know there's been tremendous economic cost to individuals and families, and I always say the biggest predictor of your health is your socioeconomic status. Overall, generally, that's true. So we need to be cognizant that we can't keep this economic damage occurring to the country as a community. So where is the balance? I don't know, but for the individual, Richard, I understand they might decide that way. As an individual, I can understand that.
And, you know, that's just a really lovely short description of all of the dilemmas that are coming to the fore in terms of making any decisions regarding COVID vaccines, opening our borders, etc. It's a very complex space and it is changing and it's evolving. I just want, oh, yeah, sure.
Yeah, look, sorry, Paul, I'm going to throw you a question without notice. This is one a patient asked me. So the vaccine is not going to really get going until December. We're seeing all these variants come out. You know, what are the chances we're going to have to just revaccinate with something else next year or do this every year?
Okay, that's a great question. And I didn't say it wasn't going to come till December. That's my extreme example if they come through on it coming this year. The question of variants is a good one. I am a big believer in cross protection generally in immune science. And why I think that the protection against a significant variant may be reduced, I do think you will have protection emerge against serious illness and death from other strains. And that's based on some of the stuff we're seeing now with some of the vaccines. Yeah, they have reduced effectiveness, but they seem to be working against seriously poor outcomes in those individuals. I don't know the answer to this, but there have been many people that suggest that's why children are not as severely affected, because there's 4 other coronaviruses that circulate widely as common colds, and children have a greater exposure and frequency to those. And therefore that and some other factors, they're getting cross protection from that. And when they've done blood studies against the SARS-CoV-2, the Wuhan strain, they find people have cell-mediated immunity protection against it who've never been exposed to it before. And that's probably coming from some exposure to these other cold viruses. So I would think a closely matched vaccine is going to be even better than that at getting your T cell immunity. I'm not saying it's for sure. It's speculative, but it falls in line with first principles of immunology. So we may need the boosters later, but I don't think these vaccines are going to have done no good. I think they're going to have done a lot of good with the variants that emerge, just maybe not as much as they would against the Wuhan strain.
Paul, thanks for that. I'm looking at the time and we're fast running out of time, which is a real shame because it's been very enjoyable on this panel. I just wonder if I can ask some quick questions. One is, do you think, and really Lucy or Sean or Paul could answer this, have we seen a drop-off of people turning up for their flu vaccines given what's going on?
I would say too early to tell from my perspective.
Too early to tell, Paul? Yep.
I would say so this is just totally anecdotal at the coalface. I would say people are still keen for their flu vax. Just the GPs and the practice owners have been totally distracted by COVID. I know we haven't had 5 seconds to scratch ourselves to organise a flu clinic.
And I know you want this to be a quick round, but I do think there's an important lesson from history. When we had problems with a flu vaccine here in 2010, we studied this and parents lost confidence in that flu vaccine, but they didn't quit vaccinating their kids against other childhood illness. In fact, it maintained at the same rate. I think that's likely to be what occurs here. People are smart and they'll know it's a problem with that vaccine. And you know, your airbag doesn't work in one brand of car. It doesn't mean you don't trust any.
A lovely example. Thanks, Paul. I'm just going to ask some short, sharp questions if I can, because the audience has sent these questions in and clearly they are top of mind for them. So the questions have to do with the timing between flu vaccines and COVID vaccines. So given the recent changes, what is your advice there?
So that advice hasn't changed. It's still, we're recommending 14 days if you can do it between a COVID vaccine and any other vaccine. So, and that's an aspirational goal. You could go shorter if there were a need to go shorter, according to the written Atagi guidance, which makes sense to me.
Great. And that's both the AstraZeneca and the Pfizer vaccines?
Yeah, a COVID vaccine of any kind, that's the recommendation right now. It's primarily based on how the studies were done. Again, it's a theoretical issue, but we've just said, let's be safe and put a 2-week break between them if we can.
Okay. We had a couple of questions from the audience saying, if your first dose was AstraZeneca, can you have Pfizer for the second dose?
That's a great question, and that study's ongoing right now in the UK. You can look it up, but there's at least in the one study I know of, there's 800 people where they're given half of them Pfizer first, half of them AstraZeneca first, and then switching their doses to see what their response is like. Based on first principles, we do this for flu vaccines all the time. We do this for pertussis vaccines. We do this for measles vaccines. You don't need the same brand, and you still get an effective response. So I'm believing at this point that switching brands is not going to be an issue medically in the longer term. That's an opinion, though, and you said not to give personal opinions. I have no data right now to back that up.
But I think you're really saying in the future, we might see a change there with the recommendations. And all the way along the line, we have seen changes when the evidence backs up a direction to move into. So I think that that's fine. I just want to, soon in the next 5 minutes, I'm going to go to Richard and he's going to summarize for us. But given the enormity of the information that is occurring and you can feel the emotion and the frustrations for staff in dealing with a whole range of things to do with the COVID rollout. I want to remind the audience that WAPHA is supporting practices to have access to the employee assistance program that WAPHA pays for practice staff. So I recently contacted a practice where they had their front staff abused, and there was a violent incident because someone turned up and wanted their vaccine at that moment, and that couldn't happen for a whole range of reasons. And it left the staff quite traumatized. These are staff in the front-facing offices. And so I said, please offer them the employee assistance program. They didn't know about it, so I wanted to make a special plug for that. That information is available on our website. It's in our newsletters, certainly the Practice Connect newsletter that goes out fortnightly. So please talk to your practice staff about that in terms of getting confidential counselling and support when that's needed. So looking at the time, we've got time just for one or two quick questions, and then I'm going to come to Richard to summarise tonight's. Okay, so actually one of the comments was, there are many questions regarding processes in our questions that were sent in. How do we do the portal ordering? What do we do if we've got issues to do with that? When will we get expected delivery dates? How do I order more vaccines? And then one of the comments came in and said, why are we getting so many emails? It's hard to find the updated information. So, Lucy, I'm going to come to you. Where can people go for the reliable information without having to, go through a whole range of websites?
So a Practice Assist website is probably a really good place to start, and we try and summarise all the information on there, but we are noticing we're getting an increase in emails and phone calls as well, up to 800 in the last month of people just asking queries because they can't easily find that information. So we have committed to put more staff onto that Practice Assist service desk, just so that we can provide timely responses to those emails and phone calls as they're coming in. We've also started a new process where we're really looking at what those questions are and trying to be a lot more responsive in getting them up into our frequently asked questions section, just so that if one person's asked the question, then it's bound to be a question for somebody else. So just trying to make that information much more accessible. And then for those of you who like to get that information through the newsletters, we're trying to repeat it all in those as well.
And I think we need to give a plug for our Practice Assist service. That's jointly funded through Rural Health West. So that's a service that is statewide, and we have considerable questions coming to the Practice Assist line from country, which is fantastic. I'm just going to raise a quote that was sent in, and Lucy, I'm going to get you to respond to this one as well, and then we'll come to Richard to summarise our discussion. But the quote was, What position will the PHN take with the Department of Health, Commonwealth, with the current confusion in the community, which has seen at least 400 people cancel their COVID-19 vaccinations at our practice in the last week? What can the PHN, Primary Health Network, do in this instance?
So we're doing a bit of an intelligence gathering exercise at the moment. So calling those practices where we know it's happening and just trying to understand if they've got any ideas of why or what's causing it. And then we are feeding that actively back to the Commonwealth to inform what their strategy might be going forward. So we're really happy to have any feedback through that we think would be useful for us, and we'll continue to collate that and pass that through to the Commonwealth.
Thank you, Lucy. Richard, I'm going to come to you now to summarise the panel discussion for us.
Well, that's a task that's particularly difficult in this one because 1 hour, 1 hour is definitely not enough. But thank you so much, Choong, Paul and Lucy for your input. What I've learnt tonight is it's definitely a moving feast because of the media, but I think that the message is very clear. Australia balances on a precipice with respect to our enjoyable situation or circumstance where our COVID numbers are really low. But that could change if we allow a delay in the ongoing vaccination process, and Paul very clearly articulated that about the balance and risk. So we need to keep vaccinating. I think that we're covering topics that everyone's feeling about: vaccine counselling and the financial cost of to the clinics to have this vaccination, but it is still a moving feast. And I link back to Health Pathways, which has all the clear information that you can get, and including our assistance program, employee assistance program, because that's really important in this difficult and challenging time for our practice staff. But I think I'd like to say is that one message I'd like you all to think about is that we need to vaccinate everyone. And I think we need to get on with it. And there's lots of reasons why that's being delayed. But at the end of the day, no matter what the media says, the patient will come to the doctors and they'll ask our opinion. And our opinion counts, in my experience, so much more. So thank you all for tonight. And I'll refer you back to Dianne to finish us off. And thank you all.
Thank you, Richard.
Thank you, Richard.
Great messages.
Great messages.
We've got some
feedback.
Richard, I wonder whether you can mute. Is that okay? I think we're better. We're fine now. So the last words are back to me in terms of thanking people. So firstly, I want to thank all of the participants who've come online after the end of a very busy day. 6:30 is a terrible time, I think, to come to a webinar. I'm sure you've got screaming children around you and people wanting to eat, and you'll want to eat. So a really big thank you for joining us tonight at this time. Please promote the recording of the panel session, the webinar, to your colleagues so that they can watch it maybe during work time. That would be good. I particularly want to thank our panel members, so Lucy, Choong and Paul and Richard. You've been able to provide your practice wisdom, your professional advice in a changing and complex world. So you've been able to summarise that for us, and that's been fantastic. So I really appreciate your generosity in terms of these times. I just want to finally say, from all of us at the West Australian Primary Health Alliance, please fill out your evaluation forms and tell us what other topics you want us to cover in these webinars. Look out for the email from us early next week, which will have answers to the questions that you've asked tonight and the ones that we weren't able to answer that you sent in earlier. And all of the resources that we've spoken about will be in that email. Finally, thanks very much again for coming. Have a lovely evening. Good night.